Welcome to the beginnings of learning about pharmacology. A little bit about me, as it's always good to get a bit of a background on the person who's presenting to you. I am a registered vet tech. My career started in 2005, and it primarily consisted of small animal medicine, emergency medicine, with some dabblings in exotics and wildlife as well. My passion across the board is teaching, whether it's teaching the vet tech and vet assistant programs, which I did for over 10 years, or if it's teaching university courses as well, which I've recently been engaged in. My general motto is a rolling stone gathers no moss. What that means for me is that I get bored easily, so I like to change things up. And I like to do a lot of different things to ensure that I don't get bored, and especially that I don't get bored in the field of veterinary medicine. So my little bit of imparting wisdom, if I may, or advice, unsolicited advice, to all of you who might be interested in staying in this career, if you're getting bored, try to switch it up. And in particular, a great way to switch it up is to volunteer. Also to travel, and if you can combine volunteer and travel, then that's the very best of both worlds. Just some pictures here. I've got top left is the Icefields Parkway outside of Banff in Alberta. The next picture is the Amalfi Coast in Italy. I've got beautiful Peru, Machu Picchu in Peru. The Berlin Wall, I've got Iceland, I've got beautiful Bon Echo Provincial Park in Ontario, and the Bruce Trail. So just a few little pieces of places I've been, places I've loved, travel I've enjoyed, to give you a little bit of an understanding about who I am and what brings me genuine joy. And then if we're on the topic of joy, I can't help but mention volunteerism. So these are some pictures from my volunteer work with the Canadian Animal Assistance Team. And the Canadian Animal Assistance Team is a fantastic organization that operates primarily in Canada. And our focus is on supporting communities, in particular Indigenous communities who are located in underserved areas across the country, but supporting their initiatives around population management and sustainable pet ownership. There are very different abilities to acquire vet medicine across Canada. Canada is a huge country, and many of the remote, isolated communities up north don't have access to vet care, or if they have access to vet care, the vet clinic might be a 3-hour flight or a 6-hour car ride or a ferry and then a flight and then a car ride. So what we do as part of this organization, we provide preventive vet care in the form of spay, neuter, vaccination clinics, and also working with communities one-on-one to support what they identify as their goals for dog animal management, so that we're definitely not coming in to just dictate what needs to be, but rather hearing what the individual challenges are within these communities and how we as veterinary professionals are able to support those goals. If you're interested in learning more about the Canadian Animal Assistance Team, I welcome you to, or I'd encourage you to check out their website, www.cat-canada.org. And I would highly recommend, if you're interested, if you like this channel, if you feel like supporting any contribution that you can, Canadian Animal Assistance Team is always accepting donations to support these volunteer opportunities. And even if you donated a couple dollars, like truly $1 or $2, if you could manage it, that would impact the organization quite widely if everybody donated $1 or $2. So that's my shameless plug for the Canadian Animal Assistance Team, which I really hope you check out and learn more about. So that's my little overview of who I am. Currently, I'm also working on my PhD in education, focusing on students and support for students when they have disabilities and they're entering into post-secondary. So that will be a whole other line of videos that I'm sure you'll find on this channel as a subset. But right now, we're not here to talk about that. We are here to talk about pharmacology and the registered vet tech. And you'll notice that I use the term RVT. RVT stands for registered vet tech. There is a difference between registered vet techs and vet techs in Ontario. Vet techs currently are not identified as registered within a regulatory body. So a vet tech might have gone to school but not written their regulatory exams, or they might be on the job trained. And that means that they don't have the same standards that they need to adhere to in regard to continuing education and regulations, quite honestly. That is changing in Ontario. We are undergoing through a legislation change. We're the first of our kind in Canada. And the Ontario Veterinary Act has been opened up and modified to include registered vet techs as part of that act. So we will in the future be called just vet techs, and of course that comes with the caveat that those who identify themselves as vet techs have to be registered vet techs themselves. So that is a complete tangent on the side. I just like to clarify the terminology. So I'll start off with a little quote. Today's veterinary technician is more than a skilled set of hands. Today's veterinary technician must know how to critically evaluate, problem solve, think, and adapt to their patient needs. And that's from Pete Bill, veterinarian, PhD, during a panel presentation on the topic of veterinary technicians and paraprofessional utilization at the American Association of Veterinary Medical College meetings in Washington. So what that's essentially saying is that it's no longer okay for vet techs to just know the basics. We are more than just a skilled set of hands. So we have to actually critically evaluate, problem solve, think, and adapt to our patients' needs. And really, the evolution of RVTs is quite significant in the field. It's comparable to nurses in the field, and just looking at how we interact with the dynamic team around us. So of course, vet techs, at some point, we were just a helping hand in the vet clinic. We were synonymous with vet assistant, with helper, with, all of these different terms, with animal care attendant, etc. And that's really shifted, really significantly shifted, not just in the skill, but also in the knowledge behind that. So if you're an RVT in the field, or if you're becoming an RVT in the field, you'll know that at times you'll get oh, you're so lucky, you get to just play with dogs and cats all day. And we know our jobs go so far beyond that. And a big component of that is our knowledge and application of appropriate pharmacological drugs. So looking at RVTs and patient care, the column on the left, diagnose, perform surgery, render a prognosis, and prescribe treatments, that is absolutely not within our realm of abilities as RVTs. Those aspects of veterinary medicine are reserved for the veterinarian and the veterinarian only. RVTs, however, have to understand the diagnosis that's provided and its implications, both for the patient as well as the environment, the owners, and the personnel who are working with the patient. We need to understand why surgery was performed if it was performed, why the prognosis was rendered, and what does that mean for the patient, for their families, and of course for us, because there's always the potential, depending on the diagnosis, that there is a public health concern as well, or the potential for zoonosis. And of course, most importantly, we need to understand why the treatment was prescribed to the patient. When it comes to treatment, we have to safely dispense, administer, we have to safely and accurately educate the client. We need to be able to monitor and analyze patient progress and provide reports to our team as well as the veterinarians. And of course, we need to recognize normal and abnormal reactions to treatments. We have to act on these treatments and these changes across the board. So it's not just having the knowledge, it's having the ability to adapt and apply the knowledge as the patient condition changes. And for me, this is what I always see as the primary difference when you have an individual who was perhaps on the job trained and they might have the understanding that they can do the vet tech's job. And absolutely, some of those skills are generalizable. They are teachable. Placing an IV catheter, sure, we can teach anybody to do that. The pieces that separate the well-trained and well-educated registered vet techs from those who are perhaps on the job trained or, partially educated or otherwise, is often that adaptation of the patient condition change. So adapting their knowledge, adapting their application of the treatments, and acting appropriately. Knowledge really is the key to application. There's so much more than just the drug name and the route of administration. It's important to recognize the physiology, the recognition of normal and abnormal reactions. And again, just going back to sealing those key critical considerations when you're understanding truly the role of the RVT versus just knowing about vet medicine. So we'll go through some of the basics of pharmacology. This is admittedly not the most exciting PowerPoint in the world. It's not the most exciting content, but it is relevant and it is important. So we'll go through it, take it or leave it, as you will. No worries either way. We'll start off with the 4 rules of pharmacology. So all drugs are poisons. That's something we need to remember. When I read that, it always reminds me of alcohol. Now, hear me out on this. For those of you who like to enjoy a alcoholic beverage periodically, we all know, or I hope you know, or you're getting to know, that alcohol is a poison. So alcohol in itself can create a really fun feeling in you. It can create a really positive sensation. It can create, a feeling of being relaxed, of stress relief, etc. And we also know that when you have too much of this particular substance, it can cause a very negative reaction, which involves alcohol poisoning, which involves significant intoxication, hangovers, alcohol poisoning, etc. I think I already said alcohol poisoning. So drugs are the same as alcohol in that way. We use them to get the desired effect, and we also have to remember that they are all a poison. So we are utilizing doses that we know are safe or are assumed to be safe with our patients so that we're not overdoing it and causing a negative effect. No drug is a silver bullet. All doses are guesses, and complacency kills. So we'll go through one of those each. I just went through this because I got too excited, but it all depends on the administration. So looking at the amount that's administered, the route that it's administered, the concentration that's administered to the patient, all of those components, those aspects of administration can create either the desired effect or an overdose or the drug getting absorbed too quickly into the body and having an adverse reaction. A good example, aside from the alcohol example that I gave you, are chemotherapeutic drugs, arsenic, organophosphates. So especially with chemotherapeutic drugs, we know that those drugs are created to kill. So they're created to destroy certain cells, destroy the bad, very quickly replicating cancer cells. But if we overdose on chemo, actually not even if we overdose, quite honestly, chemo drugs will also kill off other cells as well. So that's just something to consider. But again, all drugs are poisons, so we just have to keep in mind the dosage and why the dosage administration is all important. No drug is a silver bullet. So drugs in general alter the physiology of a patient. The goal is to maximize the benefits while minimizing the negative physiological effects. So maximize the benefits without causing adverse effects wherever possible. In some cases, no matter what, administering a drug will cause some adverse effects, and that is the risk that the veterinarian takes, that's the risk that the manufacturer takes when they're creating the drug or when they're prescribing the drug. But in general, we want to minimize those negative physiological effects. Many factors will alter the drug's effectiveness, and there's no one drug at one dose that's going to work for every single patient every time, and that's why it's not a silver bullet. So we consider things such as the patient age, the species, the gender, and not necessarily the gender, but whether the animal's intact or not intact can sometimes play a role in these things. The breed, etc., and of course the body condition score as well. So we need to know that although, let's say we use Metacam, so a little plug for meloxicam, brand name Metacam, we use Metacam all the time with patients. and we use it at a dose that is generally identified as safe, we know that not every single patient is going to react in the same way to Metacam, and that there could be unpredictability or features of unpredictability within that. And going back, oh, you can hear my wonderful needy dog in the background shaking and her collar making funny noises. If we look at body condition score, so look at this poor dog. I'm so sorry. Like I grabbed this picture from the internet, but I really hope that this is a before picture. Like, oh, this dog was, shifted to a regime, like a exercise or diet regimen, where it could be in better physical health, because that physical health of that dog, it's not good. So if you look, its nails are horribly overgrown, which means it's likely not walking, or if it is walking, it's not walking correctly, and it is morbidly obese. 9 out of 9 on the body condition score. So if we're looking at all of the factors that we need to consider when administering drugs and knowing that they're not a silver bullet, there are confounding factors such as body condition score that can cause a different reaction in one patient versus another. Okay, if we think about that too, if we're using a regular dose of a medication, let's say Metacam, 0.1 mg per kg, you have to be very cautious because the dog on the left is, probably like 22 kilograms, and the dog on the right is maybe 12 kilograms. So if you're giving them a dose based on the weight, it's going to be metabolized differently because the dog on the left is primarily made up of fat, of adipose tissue. So just little things to consider. All doses are guesses. Through clinical trials, we're given estimates, which technically are educated guesses, so educated and empirically documented estimates of ideal dosages. But don't forget, as per going back to the last slide, there are individual variables for each patient that could impact the way a medication is absorbed and tolerated within the body. And again, that could be body condition score, it could be age, it could be functionality of the organs on the inside, etc., etc. The list goes on and on. And I think this is probably the most important because I've worked, and I'm sure you will too, but I've worked with people who are complacent in their job, and admittedly, I have been complacent as well. So complacency will kill a patient, and it will kill a patient before you even realize you're being complacent. So getting comfortable with drug dosages and just grabbing the drugs that you always use, grabbing what you're familiar with, as per the vet, not double checking their dosages, not double checking the little things like the expiry on the drug, like the concentration, all of these tiny little things that I find when you're learning to become a vet tech, they can be really annoying, especially when other techs and vets are checking you, hey, did you check the concentration? Hey, just confirming. And you're doing that closed loop communication. I know it can be annoying, especially when you're starting out, but we do this closed loop communication because complacency kills. So if we get too comfortable, we start to forget rules 1, 2, and 3. We start to forget that each patient's different, that there's no silver bullet, that drugs are poisons, okay? So it's important that we don't become complacent with our practice. We often use the same drugs over and over and over and over and over in our practice, and natural complacency is bound to form. And we can't forget to maintain our vigilance, no matter how comfortable we are with the medication. Great example the other day. So I've been focusing on another area of my career for the last little bit, still engaged in vet medicine, but not in a full-time capacity the way I previously was. And my dog had a big surgery and I had to get some post-op meds to go home. And my dog is a stress case and she gets gabapentin periodically at home for fireworks, etc., etc. So she gets 3 100 milligram gabapentin capsules. So the vet at the clinic, I was there, I was doing her monitoring of my dog's anesthetic, and vet prescribed 300 milligrams gabapentin. She hands me the bottle. So my automatic was I grab 3 of the capsules, because when I'm at home, I give 3 100 milligram gabapentin capsules. So I grab 3 of the capsules, and then my RVT brain kicks in. I check the bottle, and I said, oh my God, I almost gave her 900 milligrams of gabapentin. So again, like, I've been an RVT for 20 years. I use gabapentin all the time. It's a regular in our household. But if I didn't do those checks and balances, I would have really overdosed my own dog, and that would have absolutely sucked. So take that from me. Please don't get too comfy with vet medicine. So we're going to shift into the really exciting stuff: the chemical name, the non-proprietary or generic name, and then the proprietary or trade name or brand name of drugs. Hold on to your bootstraps. This is really exciting stuff. I know it's not exciting, but we'll just go through it, okay? We'll just go through it, get through it, so that you've got the basics down pat. Naming the drugs. When we talk about a drug name, it's based on a couple things. So there's different ways to name the drug. Chemical name. So the chemical name is the long name that nobody generally repeats in clinical practice. You will see it listed on drug bottles, and you will see it, or not even on the bottles most likely, you'll see it listed on the inside pamphlet of the drugs when it talks about the efficacy and the study and the chemical compounds within the drugs. So we're looking at long chemical names, okay? So those are the actual chemical structures of the drugs. It discusses what specific oh my gosh, I can't remember my wording right now. I want to say elements, but what specific substances are in the drugs, in what amount, essentially, to create this mix, this chemistry-based mix of the drugs. Can you tell I'm not a chemistry person? And then we have the non-proprietary name, the generic name. This is the name given to that chemical compound. So the example of this, so you've got your chemical compound, which is noted above, and it has about 500,000 letters in it. The generic name is amoxicillin. So amoxicillin is an antibiotic. It's a broad spectrum antibiotic, very, very common. It goes by different names, or different trade names, but the generic name is amoxicillin, just like Medicam. So I gave the example previously of Medicam. Medicam is the proprietary or the brand name or the trade name, whereas meloxicam is the generic name. I also tend to call the generic name the drug name, so the name of the drug itself, and not the brand name. So if we go down the list, we've got chemical name, which is giant, non-proprietary name or generic name, or just drug name is fine, amoxicillin. And then proprietary brand or trade name is Amoxil. So it just depends on the brand itself, what they've named their version of that drug, and it's unique to their company, and of course they've trademarked the brand or the name. Now, one thing to keep in mind when you're working your way through generic name versus brand name, just keep in mind that a lot of times the brand name has a patent on specific concentrations of the drug. So I think Medicam had a patent. I know Medicam had a very strong patent for quite some time, and Medicam had not a monopoly, but they definitely had the market for meloxicam. And I believe when they allowed when their patent lapsed and generic brands could start making meloxicam, I'm pretty sure Medicam still owned specific concentrations. So just a word of warning with that, if you are using a generic brand or a trade name brand, just make sure that the concentration, double check that concentration of the drug. And if you're wondering what the concentration means, we will talk about that in another slide, but essentially it's the amount of the drug per mil or per capsule specifically. So this can cause confusion, just to be aware of it. There are a lot of different names and we typically use them interchangeably. Just keep that in mind, that's all. When in doubt, actually not even when in doubt, let's go back to that complacency talk. In general, always look at the bottle that you're handed. Always double check that it is the drug that you need, the drug that you're planning to administer to the patient, and always confirm that the concentration of the drug is the correct one for your use. I don't know if you can hear my sweet dog scratching the heck out of herself, but it's that time of year. And where can you find all this beautiful information? So the drug label, so on the outside, either the box or the bottle of the drug, they tend to have the basic information. So they tend to have the generic name of the drug. It would have the concentration. So if you look here, it says 5 mg per mil, and it's a solution for injection. So Metacam is the brand name. You can see the nice little registered trademark. Meloxicam is the generic name. 5 mg per mil, solution for injection. So 5 mg per mil is the concentration of the drug, and then it's telling you for what use. Is it oral dose? Is it oral as in AURAL dose? Or is it injectable? And then it gives a little bit more information as well. So it gives an overview of indications for the drug. So it gives common usages for the drug, but it doesn't always necessarily give that information. It gives your basic warnings and your dose administration. Looking for more information, more commonly you'll find the chemical name inside the box in the pamphlet, along with basics around the studies that have been completed to prove the safety and the efficacy. So generic equivalent drugs, in general, the parent company has the rights to manufacturing of the drug they had developed for a period of time before other companies can create and market the same drug. So that is what I was talking about around the patent. So Metacam, Boehringer Ingelheim was the brand, and they had a patent. So they had the exclusive manufacturing rights for meloxicam, meloxicam oral and injectable. This allows the parent company to recoup some of the costs associated with the research that they put into creating that drug in the first place. So if a drug company, if Big Pharma is going to put in the money to do all the clinical trials to ensure efficacy, ensure safety of the drug and reliability of the drug, then they're given a specific patent that lasts a identified, like a standardized amount of time. And what that does is it allows them to have an advantage in the market. So they might be the only brand out there that sells this drug, and it lets them recoup some of the costs. So it is a monopoly. It does give them a monopoly on the market for that drug. But at the same time, if they created it, they put the resources in. This helps them bring back some of those resources to pay for that. Once other manufacturers are allowed to produce the drug, they're called the generic equivalents. So that's when the patent has passed, the time has passed, now the patent is over. And the generic equivalents typically are less money, which is kind of nice for clients. And often they result in a lower cost for the original parent company as well, because of course it's based on supply and demand in the market. So are the generic equivalent drugs 100% same as the original? No, not necessarily. They do have the same drug compound, but there might be a variance in bioequivalence. So bioequivalence is the equivalent amount of generic drug is absorbed and delivered to the target site within the body compared to the original brand or parent drug. So essentially it's saying that depending on the drug itself, depending on the generic version, they have between 80 and 100% comparability to the drug. Now in most, I don't know if I'll say most, in many cases it is 100%, and there are tests that carry on through generic testing and generic brand testing as well. But just so you know that it's not always necessarily exactly the same. And I did find this was really common in vet medicine when Metacam, the brand name down here by Boehringer Ingelheim, when Metacam lost their patent and we started to get, Apopharm and Novapharm creating these, Apotex and Novapharm creating these generic versions, there were a lot of vets at the time who would not use the generic version because they were concerned with the bioequivalence of the generic versions. I would say that's not the case anymore, but to each their own. It is up to the vet what they decide to use. I think it's up to the RVT to do your research if you want to support the clinic having generic drugs available, because it's definitely more cost effective for the client, or most often it's more cost effective for the client, but it is just something to note that could happen. So extract is another term that you might come across. Extract, the term describes where the drug came from, and examples include thyroid supplements that are made from pig or cattle thyroid glands, and pancreatic enzyme powder extract derived from prepared livestock pancreas, and plant-based extracts. So that's a big word. No, that's a big sentence to say that if you're giving a medication that is considered an extract, just keep in mind that an extract is not necessarily a chemically developed drug. So a drug that was fully developed from the very basics of chemical components created in a lab. It would have been likely created in a lab, or at least formulated in a lab, but it's actually coming from true extracts from either a plant or an animal, which are supporting the outcome of that drug. So we're giving thyroid extracts to support thyroid function in patients, same with liver extracts, etc. Nutraceuticals are another, or is nutraceuticals, that category is another version of, they're not medications, but it's another category of things, things that you might come across in your pharmacy at work, in the vet clinic, or in a veterinary pharmacy. So nutraceuticals are, I'm just trying to think about some nutraceuticals right off the hop. We have various ones. They're often supplements of varying forms. The big thing with nutraceuticals is buyer beware, because a lot of nutraceuticals don't undergo the same level of testing that big drug companies would put towards their pharmacology or pharmacological products. So nutraceuticals can be amazing, and they can have a really well clinically formulated or clinically tested formula, and they can have excellent efficacy models. They can be really great, but nutraceuticals can also be garbage, like absolute garbage. And unfortunately, a lot of nutraceuticals are being marketed as, that silver bullet for so many medical conditions, and they haven't been tested properly. They haven't been clinically formulated. They haven't been clinically trialed, et cetera, et cetera. We see this in the human world as well. Like a big one is, get fit fast. Take these supplements to help improve your fat burning techniques and muscle building, et cetera, et cetera. Or here, take this supplement to cure menopause symptoms. Just buyer beware. Look at the background, look at how they were tested, who's producing the information, and whether or not there were clinical trials. So then we have other terms, which, honestly, I don't hear the term legend very often. I don't know if it's bigger in the States compared to Canada. I'm, of course, located in Canada. So over-the-counter versus legend drugs. Over-the-counter, or OTC, typically these drugs have a very, very high margin of safety, or the concentration is too low to be of concern. However, human drugs for pets will completely scrap that rule. Or if you're using an over-the-counter drug on a species that it is not identified for, that can have catastrophic effects as well. A legend drug is a regulated drug that has to be prescribed by a doctor, or like it could be a human physician if it's a human, or a generic med that are shared by humans and animals. But in general, a veterinarian has to prescribe drugs that are considered legend drugs. One thing I wanted to point out that's super, super, super important. So here on the screen, you have Advantage, and you have this very sad inbred pug. Sorry guys, folks, but pugs should not exist. I know they're lovely, but really inhumane that pugs are bred. They can't breathe. They have stenotic airways. Either way, that's another story. But this is Advantage. So if you read it, it ends in AGE. This one is for fleas and lice, okay? Advantage can be used for dogs and cats. Imidacloprid. However, Advantix is not for dogs and cats. Advantix, I hope I said ticks the second time. Anyways, Advantix is for treating fleas and ticks, and Advantix is extremely deadly to cats. It causes horrible, horrible convulsions and muscle spasms, and cats overheat. They go into these horrible tremors and they overheat and become pyrexic, and they will die with Advantix. So please, 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 please be aware that specific products are for specific species sometimes, and you need to know which ones are interchangeable across species and which ones are not. And also the dose changes on a lot of drugs depending on the species. Also, Zodiac, I want to point this one out. I'm so sorry. I hate Zodiac. I know. Nothing bad about, I don't like it. And I'll tell you why I don't like it. I don't like it because it's sold at grocery stores, it's sold at pet stores, and it is deadly to cats. And working Emerge, I used to see so many cats come in, and it's because their owners put Zodiac on them because it's a flea treatment. But again, it's pyrethrins, so it's toxic, toxic, toxic to cats. So know your species, know the dosage, etc., etc. Don't be complacent, okay? Don't be complacent. So looking at prescription drugs, some details around prescription drugs, also known as legend drugs, but I don't call them legend drugs, we call them prescription drugs. So they tend to contain ingredients that require greater control, and thus that's why they have to be prescribed rather than just acquired anywhere. So there's potential for abuse or diversion, so either taking it yourself or giving it to somebody to have them benefit from it. There's potential for harm to the patient or the handler. It must be prescribed by a veterinarian with a valid veterinary client-patient relationship. So that means that the vet, actually there's a definition in each area about what the VPCR or VCPR looks like. But essentially, it means that the vet has adequate knowledge of the patient and the condition that's being treated. And it usually requires evaluating the patient. So if your client, who you haven't seen for 3 years, calls because their basset hound has yet another ear infection, and they tell you it's the same one that he had 3 years ago and they just want the same meds, why do you have to charge me for an exam? And on and on and on. It's because the vet is legally required to. That's not the only reason, let's be honest. The primary reason is patient focus and appropriate vet medicine, the practice of vet medicine. Legally, though, if we go into the very basics, legally, the veterinarian has to examine the patient. He or she, or they, cannot take the client's word for it over the phone. So keep that in the back of your mind. In reality, we need to see the patient. We need to see the pet because we need to know what that pet's going through. Is it an ear infection versus is it something that needs to be cleaned? How's the pet doing otherwise? Is a medication going to be safe for the pet? We haven't seen the pet in 3 years, etc., etc. If the prescription drug is dispensed in clinic, the vet can give an order to the RVT, and this can to the RVT to administer the drug or to dispense the drug, and that can be done verbally, it can be done by writing in the patient's file, or it can be done on a drug order form. If it's dispensed outside the clinic, it can be done in writing with a legal prescription, and it can be prescribed verbally if the case veterinarian communicates the drug order directly to another licensed vet. Or a pharmacist, and they often have to give, I hope they have to give their license number as well. So Ontario, everywhere is going to have their own laws. I know that in general, Ontario does not like vets to act, or vet clinics to act as a pharmacy for other clinics. So that is something that locally can be discussed between clinics, but a lot of times, if you have a cottage vet and you have a downtown Toronto vet, the cottage vet doesn't want to just be a dispensing pharmacy when you're up at the cottage and their vet calls to fill a prescription. So a lot of times the dispensing vet will want to have a relationship with the client and their pet to get to know everything around that pet and what's safe and what's not. Another format of drugs are compounded drugs, and compounded drugs are Honestly, I've had so many great experiences with compounded drugs for my pets. My pets have had a bevy of health conditions over the years. And compounded drugs it's a creation of a particular pharmaceutical product to fit the unique needs of the patient. So they would take the chemical compound of the drug, so the very base unit of the drug, and they would create it into a suspension or into a tablet or a capsule, or they would combine multiple drugs together to create a specific medication. So it's interesting. It allows us to have some flexibility with the way our patients are administered medications. Really great and common example of this is hyperthyroid cats. So cats that have hyperthyroidism, they need thyroid medication every single day. So they need methimazole, which is brand name Tapazole, given every day. And if you've owned a cat, if you've treated a cat, you know that pilling a cat is not the most favorite extracurricular activity for most owners and most RVTs. I personally love pilling cats. It is one of my favorite things in the world, but honestly, I'm going to toot my own horn. I'm good at it. That's why I love it. But most normal people don't like pilling cats. So with the thyroid meds for cats, oftentimes we'll call a compound pharmacy and have them create the same medication at the correct strength and dosage to be given intradermally. So it actually goes on the ear, the pinna of the ear, and it gets absorbed through the skin. And it's really easy for the clients. Has a little bit more variability in the absorption and potentially the efficacy, and we just let the client know that. And of course, we check the blood levels every few months. But it's quite a good option for clients, and most clients are pretty happy with that. There is some controversy. I spelled that wrong. That says controversy. But the College of Veterinarians, at least when this PowerPoint was created, they might have stopped it by now because this was a little bit ago, but they did have a disclaimer. Just that the compounded drugs do not undergo the same level of testing. They don't undergo the same level of clinical testing and clinical trials as a generic or trade name drugs, which it makes sense, right? They're creating them, tailoring them specifically for that patient. So it's just something that your clients need to be aware of. So these are just examples of different compounding of drugs. Again, a lot of different options. It's a great opportunity to talk with the vet. So if you have a client that has expressed concern to you about giving their pet a medication because of the administrative pathway, so because it's an injection every day or because it's an oral med every day, something like that, then have a chat with your vet. It might be an opportunity to have something compounded. Not all drugs are able to be compounded, and oftentimes, in some cases, the vet won't want specific drugs to be compounded because the efficacy could vary. So it's just something to keep in mind, but it's a great opportunity for many clients and their pets. And there are compounding pharmacies. I believe this varies depending on where you're located. The state seems to have more options around compounding pharmacies. I'll give our local ones a little plug here. We have Summit Veterinary Pharmacy and Chiron, and they are the two that we tend to use in Ontario. I think there's also the veterinary pharmacy as well. So it's you would just give them a call, let them know the drug, let them know the concentration, the format, if there's a flavor that needs to go with it, etc., etc. And then there are different physical variations of medications across the board. This is good terminology for you to get to know on your own as part of the knowledge lexicon, the lexicon that's important in vet medicine. So there are tablets, capsules, chewable tablets, enteric-coated controlled release and sustained release, suppositories, solutions, suspensions, syrups, emulsions, and ointments, etc., etc. So just keep in mind that, again, the format, the physical variation of the medication, so the physical format of the medication and its absorption and its efficacy is completely dependent on what it's intended for. So do not give something that's supposed to go orally, no, that's not a good example. Don't give something orally if it's supposed to go topically. And a good example of that is how many clients have called us to say that they squirted Advantage in their dog's mouth and now the dog is foaming and frothing at the mouth. That is not, it's not great. It's not fun for the dog. It's safe. We know that by now. It's not going to kill the dog to do that. It's not going to make them ill. But that dog is probably pretty pissed off that they were given a topical solution by mouth. So then we have another concept just to be keeping in mind is off-label or extra-label use. So actual use or intended use of a drug in an animal in a manner that is not in accordance with the approved labeling. So what that means is the manufacturer of the drug has done a ton of studies, clinical trials, clinical studies, clinical formulations for specific species and intended uses for that drug. And there are often opportunities or situations where that drug might be used for a patient that it was not technically appropriate for based on the manufacturer's guidelines. Example of this, way back when, Medicam was never tested for cats. It was never approved testing for cats a long while ago. And finally, over time, they did the clinical trials, the clinical studies that they needed to do, and of course, we have Medicam for cats now. But let me tell you that we'd been using Medicam on cats for years and years and years at a different dose than we give to dogs because of the different physiology, et cetera, et cetera. So it's not uncommon, and again, it's at the veterinarian's discretion of how they're choosing to use it, and they shouldn't just be using it on a whim. Definitely you need to have some resources that support this, some documentation that supports this. Really great opportunity is to look in PLUMS, which is the veterinary drug handbook right here, as well as so that's a formulary. No, it's not a formulary. Sorry, it's just drug handbook. You also can look at the big formulary books, and VIN is a really great network to get recommendations, especially from specialists. But the RVT, we don't decide that, okay? That's out of our realm. Don't go chasing off-label use. So then drug orders and prescriptions, this is more terminology that you will be familiar with. A drug order is an order from a veterinarian to dispense or administer drugs. So the vet, in this example, identified that the dog has an ear infection. She writes the following order in the file for the vet tech to dispense to the client. Suralan, Otic drops, 3 drops, BID for 7 days, recheck at the 7-day mark. The tech would then prepare the medications and the prescription label. A prescription is a drug order sent from a licensed professional, the veterinarian in this case, to a separate dispensing facility, which would be the pharmacy. So it could be a human pharmacy or a compounding pharmacy, where it's filled by another licensed professional. Okay, so just a little bit of difference, but drug orders we tend to use in-house for us to internally fill the drug order. When you're creating a prescription, in most cases, this is all done automatically on your computer program that you're using at work, so your electronic medical records, your EMR. But these are the key pieces of information that need to be identified on the prescription itself. So looking at, actually I'll move on to the next one. Oh, one thing I want to highlight here is of course the veterinarian's name and license and also a signature. One piece about that is ensuring that it's legible, because if it's not legible, it could get pushed back if it's going to a human pharmacy. And then really important if you're working with large animals, so if you're working with agricultural animals that are used for food product, such as dairy cows, and where of course the farmer is going to acquire milk from them, or beef cattle, or goats that are used for meat, etc. They have to write the withdrawal times. They have to identify the withdrawal times. So how long does that animal need to be off the drugs before they can be either milked, with their milk being used for human consumption, or until they're slaughtered and their meat can be ingested by people safely. So then we have, and this is what I meant to say, I think I talked about it in the wrong slide. So the prescription back here is different. This is something that the vet would create and send to a pharmacy for fulfillment. Prescription labels, we create those in-house, and it has to have all of this information on it. And the prescription labels, most often, I hope for all of you, they are created by your electronic medical record system. However, I know that when I work in field medicine and I'm working, with no computers, no electronics in that way, we have to create our own. So we just have to make sure that the correct information is on the prescription label. And when you're working in clinic, just double check your prescription label before you put it on the medication itself, okay? Make sure that nothing was cut off. Make sure that the expiry date is correct, that the quantity is correct, that the instructions are correct, patient's correct, etc., etc. Do your due diligence and don't have complacency. Controlled drugs, there is another presentation on controlled drugs, so we'll just have a little brief overview of them here. Controlled drugs are substances that have potential for abuse, so either physical or physiological addiction. And they all come with a rating. So the rating's based on the risk for abuse. We have classification 1 to 5. Classification 1 is greatest risk of abuse or for abuse, and class 5 is lesser risk for abuse. Examples of class 1, we'd have heroin, LSD, no medical value, cannot write prescriptions. So we don't use those in vet medicine. Class 2, we have phenobarbital and fentanyl. So we can write prescriptions for these, not we, the veterinarian, but more strict rules are in place for these. So we can't allow refills, need child-proof containers, must be documented precisely. And with these as well, a lot of time we're giving them in-house for a patient. So thinking about fentanyl, we'll often use as a pain medication in injectable format in clinic for a patient rather than sending it home. I don't know any clinics that would send fentanyl home at this time. The opioid crisis is immense in the country and in North America in general. And realistically, opioids rarely go home with patients. They do, but it's not overly common. The one format that you might see fentanyl administered to go home would be a fentanyl patch, and that's a transdermal application. And it's often given after an extensive surgery for a patient. And it's typically well secured, but at the same time, a lot of precautions go with that. So with controlled substances, they have, and again, your local veterinary college will have specific requirements on how controlled substances are kept. And they're in line with public health as well. But in general, it's secure storage is legally required. Has to be attached to a structure, so not in a tackle box that could just be walked away with. Locked at all times with limited access. It's recommended to keep the prescription pads in storage as well, so that somebody can't snag a prescription pad, write themselves, a pretty awful prescription for fentanyl or otherwise, and bring it to a pharmacy. With us, with RVTs, it's an interesting one. So the vet is responsible for the controlled drugs overall. However, the RVT is usually doing most of the drug logging, so the documentation of the drugs and the use of the drugs. One thing that you want to remember as an RVT to protect yourself and to protect the vet as well is that more than one person should participate in drug log audits at all times.